Welcome back to the second part, and in this part I'll be talking about peptic ulcer disease and the inflammatory bowel disease. So peptic ulcer refers to two conditions: the gastric ulcer, when the ulcer occurs in the stomach, and duodenal ulcer, when the ulcer occurs in the duodenum. The incidence of this condition has been increasing because of the NSAID use, and what happens is that the natural defense mechanism against the ulceration in the stomach overcomes or overwhelms the protection or the lining that protect the stomach, and this would lead to ulceration. For duodenal ulcer, the reason is again the acidity. However, we know that the duodenal ulcer are not prepared to receive acidic content, and within the duodenum, as the chyme, which is the product of digested food in the stomach that is mixed with the acids, as this chyme gets into the duodenum, several products are excreted to reduce the acidity. So when there is a problem in reducing the acidity of the chyme product, or when the chyme is far much more acidic than it should be, that the acidity would not be buffered by the products produced within the duodenum. In this case, it will remain acidic and it will lead to ulceration of the duodenum. So acidity is the main problem. However, in the gastric ulcer, the gastric mucosa is already prepared and designed to accommodate this amount of acidity. So the problem is mainly lies within the lining of the mucosa of the stomach, or the mucus protection, or the mucus layer that protect the stomach. And also it has been shown that Helicobacter pylori, which is a strain of bacteria, was far much more common to be found in patients with a peptic ulcer, whether gastric or duodenal ulcer. So when a patient is having a peptic ulcer, he's always being investigated for the presence of Helicobacter pylori, because it should be treated with antibiotics, and because of the high risk of malignant transformation that is harbored when these bacteria are present. Okay, so let's see what goes on in a peptic ulcer. So this is an example of a gastric ulcer, and it's just an ulcer that occurs within the lining of the stomach because of the failure of the mucosal lining and the mucus layer that covers the the stomach. They failed to protect the stomach from the excessive acidity. And as you can see, the ulcer can go deep into the layers of the mucosa, submucosa, even perforate the muscle, and this would lead to massive bleeding within the stomach. Of course, this bleeding or this blood, when it is mixed with the acid, it will turn out into like a dark brown coffee-like substance. Right, and the gastric ulcer is less common than duodenal ulcer. It's like 3/4 of the peptic ulcer are actually duodenal ulcer. Only 1/4 of the peptic ulcer are really gastric ulcer, because I said the stomach is already prepared to receive this amount of acidity. So we really worry about the gastric ulcer more than duodenal ulcer, because there is higher chance that this ulcer could be malignant, and we need to investigate and check whether this ulcer is just representative of a failure of the lining mucosa to handle the acidity of the stomach, or it is actually an early sign or initial sign of a malignancy within the gastric mucosa. So what is usually done when a patient is having a gastric ulcer. This should be investigated further by doing a biopsy. So there's endoscopy is being done to check the presence of an ulcer. Once the ulcer is detected, part of this ulcer is taken for a biopsy to check for any malignancy. Sometimes the patient should go for several biopsies repetitively if the ulcer persisted to be there, because it is possible that with long time this ulcer could convert into a malignant ulcer, and this need to be followed up. The signs and symptoms is gastric pain again. But what is peculiar about the gastric ulcer is that the epigastric pain is increased when the patient eats food. This is completely the opposite from the duodenal ulcer. In duodenal ulcer, the epigastric pain is relieved when the patient eats food. So this is how to make the difference whether it is a gastric or duodenal ulcer. How it is being treated. So as the lining of the stomach fails to handle the acidity present in the stomach, we try to reduce this acidity by using the antacids. Another thing that should be done is to treat the Helicobacter. So this is treated with antibiotics. 3 types of antibiotics are being used to manage or to treat the Helicobacter. This is how endoscopy is being done. So the patient through the mouth get this endoscope, and then the endoscope, it just check the mucosal lining. When there is an ulcer or when they can see an ulcer, they would take a biopsy of that ulcer, checking for any malignant changes and checking for the presence of the bacteria, the Helicobacter pylori bacteria. The duodenal ulcer, as we said, it is far much more common than the gastric ulcer. Lower chances of being malignant than a gastric ulcer, and again it is treated by reducing the acidity of the chyme by using the antacids, H2 receptor antagonists, and PPIs. Again, we use antibiotics because it is associated with Helicobacter pylori. And here is the difference. As we said, they are both, the duodenal ulcer and the gastric ulcer, are presented by epigastric pain. The patient would feel pain like in the stomach area, just in the diaphragm area, and this pain can be referred again to the chest, to the arm, mimicking MI. But the patient would say that when I eat something, this would relieve my pain. When I drink some milk, this would relieve my pain. This is quite the opposite in the case of a gastric ulcer. In a gastric ulcer, the patient stops eating because this reduces his pain. Whenever he eats food, he will feel the epigastric pain. So this is about the duodenal and gastric ulcer. Both conditions occurs more frequently in males than females. This is another thing that I forgot to say. The other condition that affect the lower GI tract is the inflammatory bowel disease. What is an inflammatory bowel disease, or we refer to it as IBD? It is idiopathic, so the cause is unknown. It is chronic, so it lasts for several years, so many years, and it is relapsing, which means it just flares up and then subside and then return the cycles. There are cycles of flare-ups along the course of the disease. And what is it? It is an inflammation of the GI, mainly the upper part of the GI, and we refer to the duodenum, or for the Crohn's disease, actually it's any part of the GI, starting from the mouth, ending with the anus. So any part of the GI could be affected. In ulcerative colitis, it's mainly the colon that is affected. Other parts of the GI system are being spared. So this is what happens. So there's a relapsing inflammation of the GI system. Why does it happen for some people, not the others. Of course, there is a genetic susceptibility. So these people have or are more susceptible, genetically susceptible to develop this disease than other people. And what has been noticed is that the prevalence of these conditions are becoming more and more increasing, particularly in developed societies. So there's one of the theories explaining the etiology of the disease is the hygiene hypothesis, which means that as the humanity become more civilized, more advanced, they tend to care more about the hygiene, and this would eliminate lots of normal microflora. And remember, we stated that the normal microflora or the microbiome is very important in maintaining the integrity of the immune system, and by being extra hygienic, this would eliminate lots of bacteria and essential flora. This would make the body react aggressively to any minute changes that it used to tolerate previously. So this is one of the theories that explains the rise of the prevalence in the inflammatory bowel disease. This image here shows you some, how factors integrate together to form or to make the patient or the person susceptible to develop inflammatory bowel disease. So as I stated, the genetic susceptibility being having certain genes, which makes the immune responses more active, more exaggerated. Certain environmental factors, including certain types of food, preservatives, for example, reduce the amount of vegetables and fibers in our diets, and relying more on the synthetic substances within our food or manufactured substances within our food. The immune response having more sort of a more atypic or more ready to go immune response, more hyperactive immune response would make you more susceptible to develop inflammatory bowel disease. And eventually and lastly, the gut microflora, which has been changing because of the hygiene trends that comes with the civilization. So all of these are put together to make a person more susceptible to develop inflammatory bowel disease. What's the difference between inflammatory bowel disease, the ulcerative colitis and Crohn's disease? As I said earlier, so Crohn's would affect any part of the GI, while the ulcerative is more limited to the colon. And in the ulcerative colitis, it's only the mucosal layer are being affected. However, in the Crohn's disease, the mucosa would look normal, but there's sort of a thickening in the layers of the mucosa that would make it look like a cobblestone with rough surface, as we will see in the coming slides. And the ulcerative colitis, it affects the whole colon. So the patient would have the whole colon affected with the condition. However, in Crohn's disease, although it affects the whole GI, but there's sort of a skip area. So maybe you can see the disease affecting the oral cavity, then the esophagus and stomach are okay, duodenal is affected, jejunum is okay, and so forth. So there are skip areas within the GI system. The complications of the diseases are different. So in ulcerative colitis, usually patient would have diarrhea, severe diarrhea, bloody diarrhea. This is not really the case in Crohn's disease. However, the patient would have a higher chance to develop abscesses and fistulae within the GI system. So this is how the normal colon would look like. This is how the colon would look like in a patient with a Crohn's disease, and this is how it would look like in a patient with ulcerative colitis. So you can see here there's a thickening of the of the lining and lots of fissuring, so which makes it more susceptible to develop fistulae and perforations. And you can see here the inner surface, it's more of an irregular, we call it cobblestone appearance. The appearance of the ulcerative colitis is completely different. There is atrophic changes, there is lots of ulceration, erosions within the lining of the colon, and this explains why the patient would have lots of bloody diarrhea. Of course, there is diarrhea because there is no absorption of the fluids, mainly that occurs in the colon, so the patient would have diarrhea, very loose stool, and it is bloody because of the presence of ulceration. This is another slide just making comparisons between the ulcerative colitis and Crohn's disease. Diarrhea, as we stated in ulcerative colitis, blood in stool, which is the characteristic of the disease. Well, it's actually very rare in Crohn's disease. Toxic dilatation, which means megacolon. So the patient would have bloating and the colon would become so huge, and this is sort of a case of emergency. Another thing, Crohn's is more painful than ulcerative colitis. Abdominal mass is rare in ulcerative colitis, but it is seen particularly in the right quadrant of the Crohn's disease that would induce pain, and the patient might go to the emergency department thinking that he's having appendicitis. So this is how Crohn's disease is affected. Fistulae and obstructions are common in Crohn's disease, but rare in ulcerative colitis. Fistulae occurs because of the fissuring, and obstructions because of the thickening. This is not present in the ulcerative colitis. What we have in ulcerative colitis is excessive ulceration that will lead to bleeding and diarrhea. So clinically, they look different. They are presented differently. Crohn's disease, how it is presented in the oral cavity. So in ulcerative colitis, there is no oral presentations except for changes that might occur due to anemia, because patients with bloody diarrhea would eventually develop anemia. And so this would be presented in the oral cavity as atrophic tongue and pale mucosa, etc. Ulcerations, for example. In oral Crohn's disease, as we said, that Crohn's would affect any part of the GI, including or starting from the oral cavity, so we can see changes within the oral cavity related to Crohn's disease. This is one point. Another point is that in ulcerative colitis, it is more severe with the severe sudden diarrhea and excessive blood in the diarrhea. This would make the patient so concerned, and he will usually go and see the doctor. So it's very unlikely that you will diagnose a patient with ulcerative colitis based on the oral finding. Usually the patient is already diagnosed because of the severe symptoms. However, in Crohn's disease, the patient might have sort of mild symptoms, and you might be able to detect a patient with Crohn's disease that have started developing the disease by seeing changes within the oral cavity. And in this slide, I'm showing you some of the changes that might occur within the oral cavity. And the coming slide, we will see the images for these changes. So swelling of the lip, mucosal tags, cobblestone appearance might occur in the oral cavity, ulcerations, whether resembling RAS or non-RAS ulcers, can be present either as part of the disease, like one of the disease presentation, or they could be just secondary to the malabsorption that is accompanying the disease, leading to hematinic deficiencies. Angular cheilitis and fissuring of the lip is another presentation, and actually it is part of the disease presentation. So Crohn's disease would have fissuring within the lining or within the GI tract, and would have anal fissuring, and also would have lip fissuring. So this might be related to the disease presentation, lymphadenopathy, full width gingivitis, and perioral erythema. So this is example of how swelling would occur in the oral cavity or in the lips here, as you can see. This is minimal fissuring. For some patients, the fissuring are so deep and so severe with bleeding, and this is another example of fissuring occurring on the corners of the mouth, known as angular cheilitis. And when you palpate the swelling, it is firm in consistency, it is chronic, it has been there for a while, so it is not sort of an allergic swelling where there's edematous fluctuation within the lip. It is actually more of a rubbery consistency, as it consists of thickening of the mucosa with granulomatous tissues. This is the cobblestone appearance. This is how the colon looks like in a patient with a Crohn's disease, and very similar appearance can be seen in the oral cavity, not as nicely presented as in the previous slide, but you can still see the cheeks here. You can still see the irregular surface, like cobblestone appearance within the oral cavity. This is an example of tissue tags. So there's lots of tissue tags, which means growths or exaggerated growths within the oral mucosa that might appear in the cheek, in the gingiva, and the retromolar area, which is the most common site for tissue tags to appear. And you might see also ulcerations. This is an example of non-aphthous ulceration. This is here we can see anaphthous-like ulcers. So these are again presentations of the Crohn's disease within the oral cavity. This is an example of non-brass-like ulcers that can be seen in a patient with a Crohn's disease. And this is a really peculiar picture of the full involvement of the gingiva with the small pustule-like eruptions. This condition is known as biostomatitis vigitans, and this condition has been linked to inflammatory bowel disease. Like any patient with this presentation should be investigated for IBD because it is highly linked and associated with the IBD. However, we can see biostomatitis vigitans occurring or happening just without any GI involvement, but this is very rare. How to diagnose inflammatory bowel disease? So having the clinical picture would make the specialist, or should make you more susceptible, should make you more how to diagnose inflammatory bowel disease. Having the peculiar clinical picture should warn you or should make you alert about the possibility of inflammatory bowel disease, and you should refer the patient to the GI specialist, and the GI specialist would confirm the diagnosis using endoscopy and taking a biopsy to check for these changes that we discussed earlier. Laboratory finding, they are not really specific for inflammatory bowel disease. Increased ESR and C-reactive protein is suggestive of the presence of inflammatory condition. However, ANCA, which is anti-neutrophil cytoplasmic antibodies, they are really or usually are very high in ulcerative colitis. So, however, we can see ANCA raised in other autoimmune or immune-mediated conditions, but in ulcerative colitis it's really high. The patient is usually anemic because of the blood loss. So this is how it is diagnosed. The mainstay treatment is sulfasalazine and 5-amino salicylic acid, which is an anti-inflammatory medication. So this is the main number one treatment for Crohn's disease. Some patients might need steroids to control the inflammation, or others might need immunosuppressants because we don't like to rely on steroids because of their side effects. So Whenever it is hard to control the inflammation, we try to use non-steroidal medication, or steroid sparing drugs we call them, like azathioprine or cyclosporin. Anti-TNF, which is one of the new medications, we call them the biologics, are being used for treating the IBD. And the other thing is, you need to manage the patient, not just the inflammation, so you need to correct the deficiencies that took place. So the patient needs a replacement for the different like iron, B12, folic acid, and other vitamins that are absorbed within the within the intestine and the colon. So we need, like, including vitamin K, for example. So the patient should be monitored for these deficiencies, and these deficiencies should be corrected. Surgery is used only for resistant cases, when there is perforations, for example, or when there is extensive ulceration. A section of the very ulcerated colon might be taken off, or if there's an area of fistula, or this would be surgically treated. This is the end of part 2. See you in the third part. Thank you. Bye-bye.